Good morning. My name is Sarah Lowry. I'm a student physical therapist assistant from Jeff State Community College. And today I'd like to talk with you all about Kaposi sarcoma. It's named for Dr. Morris Kaposi, a Hungarian dermatologist who first described this disease in 1872. It's more commonly affiliated, though, as the age-defining illness. It is a skin cancer that spreads that is skin deep and goes beyond, spreading from the skin to lymph nodes, mucosal surfaces, and even possibly internal organs. Its parent virus is the HHV8 that has 4 cellular markers that attaches to particular cell types like endothelial cells, dendritic cells, macrophages, and smooth muscle cells, and then they undifferentiate them from themselves. Today's discussion will be regarding the pathology, its categories and descriptions, risk and effects as to who gets it and what happens, and then the treatment, medical, physical therapy, and precautions regarding it. To begin the pathology section, it will help you, the listener, to know about the 4 different categories of KS. The first one is the classic. It was the first identified form, and it typically affected elderly males from the Eastern European Mediterranean region. It manifests in hands and feet and spreads to arms and legs, occasionally affecting mucosal surfaces and internal organs. It is the one, though, that could possibly have spontaneous regression. Note the lesions on the 4th toe in the picture. The second type is endemic African, and it typically affects young children from the sub-Saharan region. It presents strongly in the lymph nodes and runs a high risk of infection due to ulceration and lymphedema. If you can see on the picture, there's an ulcerated area, and you can note the lymphedema in the photograph. Third category is iatrogenic or post-transplantation, primarily affecting males who have been on immunosuppressant medications for 2 to 5 years. It strongly affects mucosal surfaces and internal organs and leads to a poor prognosis for the patient. You can note the lesions on the oral cavities with the arrows. Finally, the 4th type is epidemic. It was first reported in 1981 and is associated with HIV and AIDS. Call that the textbook picture that actually did come out of my A&P textbook. It affects all systems as previously mentioned, and it's unpredictable as to localized or widespread effects, so there's no clear prognosis for the disease. Regarding diagnosis, certain tests can be performed, such as blood tests, outpatient tests, to determine if a person has KS and to what extent. For the blood test, it can be found in plasma, and then you look for the HHV8 and elevated red and white blood cells. The red and white blood cells lead a doctor to determining if there's a tumor present and what type. Outpatient tests can include endoscopies, which look at the GI tract and how it's in there and what's affected, bronchoscopies for the lungs to see if it has occurred there, other biopsies as to effect in the skin, CT scans, and Doppler scans. Early detection is the key because KS is not curable, but you can prevent spread and functional limitations and impairments. If you quickly intervene, you can educate the patient on disease process and limit the areas affected by KS. Our next section will discuss risk and effects of KS. As mentioned in pathology, each category does have its specific target population. So the people that are in effect getting this, I wanted to break it down geography, where KS is located in the world. Up to 50% of people afflicted live in Africa, 10 to 30% in the Mediterranean, and less than 5% in Western Europe and USA. For post-transplant patients, we mentioned about the medication, but also you have to keep in mind you have increased age and survival rates, which might lead to the KS exposure, as well as they might have been exposed to HHV8 pre or post-transplant. And in the HIV/AIDS group, KS is the first sign of HIV in 10 to 12% of patients. 10 to 24% of patients have KS, and 20,000 HIV patients are more likely to develop KS than any other group. These pictures are going to speak 1,000 words. And what I want to quickly talk about is how each of them have KS, but it presents so differently in each one. In the top left, that gentleman has lesions in his axilla area and right below the bicep. So you have to think about what problems he might have. Pain, range of motion, he might even experience amputation due to the skin breakdown. This bottom left picture shows the KS lesions on the intestines. What would that patient face? Again, pain, weakness, and of course bowel irregularities. This last picture here on the right, this lady has lesions in her eyes, spreading on her face, and going down towards her trunk. So what type of problems would she have? Again, pain, visual impairment due to edema, and also issues with her appearance. Now what? They haven't. Why don't we break this down in regards to the Nagy model of disablement? In regards to pathology, it is the KS and what we've described, plus secondary pathologies like HIV, amputation, transplantation. Impairments include pain, edema, impaired skin integrity, muscle weakness, and decreased range of motion, gait, and balance. Functional limitations would be decreased activities of daily living and independence. Disability would be their decreased participation in society. It might not be so much the disease, what it's done to them, but how it looks on their bodies. And worst case scenario, death. Our final section is on a more positive note, how we treat it once they get it. First, medication is highly popular. For the HIV and AIDS patient, they can have the traditional HAART therapy, which is highly active antiretroviral therapy, and what it does is it keeps the AIDS patient from getting those secondary conditions that make them ill. For the post-transplant patient, there is the possibility of reducing or ceasing their immunosuppressant medication. However, that's sometimes not a viable option due to those medications keep them from rejecting their organs, and most of the patients are on those medications for life. You can have surgical excision if their lesions are close to the skin. And then therapies, cryotherapy, freeze it off, radiotherapy, which is local, and chemotherapy are options. However, chemotherapy would not be the first choice because of its widespread effects and affecting immune suppression in other ways. And what we're all interested in as future PTAs, physical therapy. PT intervention can include these types of steps that we do with patients on a daily basis. It's very important as PTs to gather patient information such as verbal history, lab values, and diagnostic results in order to guide our plan of care and determine particular participation levels in PT. Our manual, the Guide to PT Practice, has 5 preferred practice patterns for people with KS. 1 under the CV pulmonary section, which is pattern H, and the other 4 under the integumentary section, patterns B through E. At your convenience, review those so you know how to best treat those patients. Each patient has a unique individual response to KS, and I've learned more about it when I was reading case studies and researching the role. For example, there were 2 patients that had gait dysfunction. One had to use a wheelchair, one just limited activity. They did these type of interventions. The man with the lymphedema and reduced his activity got compression garments. The man with the wheelchair got orthotics, and so that allowed him to be able to walk on the lesions without experiencing pain. Another case study involved amputees. With the amputees, they received those type of interventions as well as gait training and training on their prosthetics. One patient unfortunately had widespread KS and passed away. Another patient was bilateral amputee and didn't feel like it was worth his risk. But the 2 other patients in the study, they were able to ambulate and walk in spite of the presence of lesions. So as you can see, physical therapy is very crucial and helpful to patients. When we discuss treatment of patients, we have to keep in mind certain precautions. Standard precautions are always present. Even though KS itself is not contagious, they could have infectious wounds or again the presence of HIV or AIDS. So again, use your mind, make sense, treat them, wash your hands. They could have medications that affect them in different ways, such as making them feel weak or prone to other infections. So you might want to watch what their tolerance is for the day and keep them away from other patients that might be ill. If the KS is present in other organs, such as the lungs or GI tract, they could have dyspnea, chest pain, cough, abdominal pain, nausea, and vomiting, which would be a tolerance that would be lower for their treatment. And finally, the emotional status. You've seen the pictures, you see how they look. Pain is the #1 thing I keep talking about. So they have normal barriers to living, stigma of being a patient. They might not even come to clinic for their treatment. In conclusion, to reiterate, KS is a complex disease that affects individuals differently, can have either positive or negative prognoses based upon early diagnosis and treatment. It is very crucial in order to begin a treatment plan as quickly as possible to maintain function and reduce risk to internal organs, limbs, and even possibly life. The effects of KS are so clinically diverse that treatment must be individualized based upon impairments and limitations. Keep that in mind as PTAs treat the person, not the disease. As always, address any questions or comments you may have via Blackboard. Thank you all so much for your attention.